So the early distinction between NMOSD and MS is critically important to choose right treatment for right condition.
So we know that MOGAD can occur from 0 to 90 years. Well, of course, we know that MS and NMOSD are especially more common in the middle age, young age, middle age. MOGAD is quite common also among children, which is another important difference, and is as common as in female and male, which is another important difference in comparison with MS and NMOSD.
The NMOSD treatment is divided into three phases. Acute phase treatment, long-term treatment to prevent relapse, and symptomatic therapies for the neurological sequelae.
So I think it's very much important for the differential diagnosis of all these three conditions, and also because treatment, if we give the wrong treatment to patients because we did maybe a not proper diagnosis, then the risk of increasing disability and the risk of relapses is very high. I'm Sara Mariotto, I'm a neurologist and researcher, and I work at the Neurology Unit, University of Verona in Italy. And I'm the responsible for the diagnosis and management of patients with neuroimmunological conditions, and in particular NMOSD, MOGAD, and autoimmune encephalitis.
Hi everyone, I'm Kazuo Fujihara. I'm a professor of neurology at Fukushima Medical University, Department of Multiple Sclerosis Therapeutics. And I'm a clinical neurologist and have been doing clinical research on NMOSD, MOGAD, MS, and related disorders.
And I'm Brett Drummond. You're listening to the ECTRIMS podcast, the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. While MS is the most well-known autoimmune disease of the central nervous system, there has been an increasing focus in recent times in understanding and characterizing rarer conditions, including myelin oligodendrocyte glycoprotein antibody-associated disease, or MOGAD, and neuromyelitis optica spectrum disorder, or NMOSD. These diseases have their own set of complications and complexities around pathogenesis, diagnosis, and treatment. In part one, we discussed a number of really interesting and pertinent aspects of current research and understanding into these two conditions. For part two, I'm once again joined by Kazuo and Sara, and we will be continuing this fantastic discussion. Interested to know what the latest research tells us about the pathogenesis of this condition. Both mentioned that obviously the diagnosis of these requires these live cell assays, that the confirmation of the antibodies or the confirmation of the target of the antibodies is important. Does that mean that we know what the targets are in this case, as sort of separate to MS, I guess, where we're not entirely sure what the targets are?
Yeah, so the pathogenesis of MOGAD is quite difficult. I mean, it's less well established than that of NMOSD or multiple sclerosis. What we know that the pathology of MOGAD is mediated by T cells and, of course, complement-mediating antibodies. And we also know that the antibodies need to reach the CNS and to recognize conformational MOG. And this is why we need conformational cell-based assay to diagnose MOG, so to demonstrate the presence of MOG antibodies. But in vitro, they've demonstrated that MOGAD can activate complement and induce cellular-dependent cytotoxicity. The main problem is when we move to in vivo models and also animal models, where we are not able to recognize, as we did for aquaporin 4 antibodies, in the same clear way the pathogenesis of MOG antibodies, which doesn't mean that MOG antibodies are not pathogenic, but it means that maybe we need to study this aspect more in depth. So the main problem probably is related to the titer of the MOG antibodies that we need to demonstrate their pathogenic role, but also to the fact that sometimes they do not recognize the rodent epitope. So it's quite more difficult to demonstrate the pathogenesis in animal models, but I think that we should, of course, work more on that.
Yes. Well, as I already mentioned, the main target of aquaporin 4 IgG positive NMOSD is astrocytes, because aquaporin 4 is a water channel protein richly expressed on the end feet of astrocytes, which is quite different from the demyelination is the the main pathological finding of MS. Although myelins and neurons are also damaged, severely damaged in aquaporin 5GG positive NMOSD. So aquaporin 5GG positive NMOSD is essentially an autoimmune astrocytopathic disease rather than inflammatory demyelinating disease of the central nervous system. So aquaporin 5GG is an important diagnostic biomarker, but it has been revealed that aquaporin 4 IgG is pathogenic. Aquaporin 4 IgG is essentially IgG1, which can efficiently activate complements. And by the mechanism of complement-mediated cytotoxicity, astrocytes are destroyed. But what we do not understand is the trigger of relapse, where infections and some other cytokines, for example, IL-6 is known to increase the permeability of the blood-brain barrier, and some autoantibodies like GRP78 antibodies is known to increase the permeability. But still we do not fully understand what triggers the increased permeability of blood-brain barrier that will lead to the acute exacerbation or relapse of NMOSD. If we understand fully the trigger, then we may be able to prevent the development of NMOSD. And aquaporin 5GG is pathogenic. So, we found that the patients with NMOSD were seropositive for aquaporin 5GG years before the onset event of NMOSD. So those patients were seropositive for many years, but they did not develop the disease until the onset event. So again, the aquaporin 5GG is pathogenic, but as long as they are just circulating in the blood and do not cross the blood-brain barrier to contact astrocytes, there's no NMOSD. So if we can maintain the integrity of blood-brain barrier throughout the life of the aquaporin 5GG positive patients, they may not develop NMOSD despite the seropositivity for aquaporin 5GG. And of course, there are some white blood cells like granulocytes or lymphocytes may also be involved in causing the tissue damage in this disease. But T-cell response to aquaporin 4 have been reported, but further research is needed to clarify the further details of the cellular immunity in this disease.
A couple of quick questions, sorry, just to expand on a couple of those points. Are there individuals who are aquaporin antibody seropositive, who never go on to develop NMOSD? Or do we see those in healthy individuals, or will they always at some point? We don't know.
That's a great question, and I'd not exclude the possibility. One patient that I experienced developed the onset event, but we found that she donated blood before the onset of NMOSD. And we found that the blood that were drawn over 10 years before the onset of NMOSD were also positive for aquaporin 5GG. So she was asymptomatic for more than 10 years, despite the fact that she was positive for aquaporin 5GG. Are there any patients who are seropositive but never develop before the end of his or her life? That's a great question.
Something that I guess is hard to know, but would be interesting to find out, I guess, to see if there's a difference between those individuals and ones who then go on to try and work out what that trigger is. Similarly, sorry, just to continue on, it's such an interesting topic. I think you said originally that there were also some people with NMOSD who were seronegative for these aquaporin antibodies. Do we know what the target is in them? Is it still astrocyte destruction, but a different part of an astrocyte that gets targeted, or is that something that we're still unclear on?
Well, so as I mentioned, a fraction of aquaporin 5GG negative NMOSD patients are positive for MOGAD. So those patients have demyelinating disease. But as for doubly seronegative NMOSD, a Korean group reported that the serum or CSF GFAP. GFAP is an astrocyte protein. So the detection of GFAP means the astrocytes are destroyed. And they found that unlike aquaporin 4 IgG positive NMOSD, GFAP, especially in the CSF, was not elevated in EE seronegative NMOSD. So unlike aquaporin 4 IgG positive NMOSD, a EE seronegative NMOSD is not inflammatory astrocytopathic disease. That is the fact we know. And another point might be that EE seronegative NMOSD may not be a single disease. It may be heterogeneous in nature. So that is another difficulty to do research in this group of patients.
As for the biomarkers that you mentioned, like GFAP or, for example, NFL, they have been proposed as potential marker of disease activity in different conditions. So, for example, NFL, we try to demonstrate these, but are not the best marker to monitor disease activity in MOGAD, according to our studies, because they increase quite a lot at onset, but they increase a little bit after relapses, but they can't help differentiating monophasic and relapsing cases. As for GFAP, this is a marker of astrocytopathy. We know that astrocytes are not the main target in MOGAD, so it seems not the best a marker to monitor disease activity in MOGAD, but we measure some patient with seronegative NMOSD, where you know that it's quite different to diagnose these cases, and we measure GFAP in these patients. We observe that GFAP levels are usually lower in seronegative NMOSD in comparison with seropositive cases, while NFL are quite similar. But we also noted some patients with increased GFAP levels and seronegative, double seronegative NMOSD, so no NMOSD seropositive, no MOGAD, but increased GFAP values. This could mean that in some seronegative cases, we anyway have an astrocytopathy, so maybe a novel antibody is linked with astrocyte. And we are now going to increase the number of study cases and also to try to explore more on this possible astrocyte target.
And although both aquaporin 4 IgG and MOGA IgGs are essentially IgG1, so they are supposed to efficiently activate complements, but we previously reported histopathological findings of NMOSD and MOGAD. And in aquaporin 4 IgG positive NMOSD, there were dense depositions of activated complements in the perivascular regions of the NMOSD lesions. But in contrast, in MOGAD, the deposition of activated complements were much milder. Although there are some exceptional cases in which the dense deposition of complements were seen, but overall, compared to NMOSD, activated complement deposition in the tissue of MOGAD lesions were much milder. We do not know why, but as Sara mentioned, there may be some differences in terms of the pathogenicity of autoantibody amounts, and other factors may be involved. But this is a critically important point, because probably we will discuss it later, but anti-complement therapy is quite effective in preventing relapse of AQP4 positive NMOSD. But based on the findings of complement deposition, anti-complement therapy may not be so effective in MOGAD compared to aquaporin 4 IgG positive NMOSD. We do not know, but that may be a very important point from the viewpoint of treatment.
Yeah, well, let's continue with that thread. What are the current treatments for these conditions, and also what are currently in clinical trials, and what new therapies may be coming through the pipeline in the next few years?
Well, thank you. So the NMOSD treatment is divided into three phases: acute phase treatment, long-term treatment to prevent relapse, and symptomatic therapies for the neurological sequelae. During the acute phase, usually the high-dose methylprednisolone is the first-line treatment. But studies demonstrated that maybe up to only 20% of the cases treated with high-dose corticosteroid showed complete recovery. So 80% of the cases showed incomplete recovery. Then, as a rescue therapy, plasma exchange is started, but you have to start plasma exchange as soon as possible. A European study showed that if you start plasma exchange later than 5 days of the onset of acute exacerbation, response rate was much lower compared to the earlier treatment. So, for example, if you continue high-dose corticosteroid for 5 days, and then if you judge, the treatment effect is not effective, that may be too late. So some experts say that we should start plasma exchange as soon as possible, or we may use plasma exchange as a first-line treatment, not to miss the therapeutic window. So that's one important thing. And occasionally IVIG may be used to treat some cases with acute exacerbation of NMOSD. And as for long-term relapse prevention, until several years ago, immunosuppressants, CD20 monoclonal rituximab, and corticosteroid were used. But in 2019, the results of the 3 important international clinical trials were reported. The 3 monoclonal antibodies, namely the eculizumab, anti-complement C5 monoclonal, and the satralizumab, anti-IL-6 receptor monoclonal, and inebilizumab, CD19 monoclonal, were found to be highly effective in preventing relapse in aquaporin 4 IgG positive cases. Relative risk reduction is maybe 80% or over 90%, so highly effective. But so far, the efficacy of those monoclonal antibodies in seronegative NMOSD are unclear. So this is a research challenge for us. So we have to study more about the treatment options of seronegative NMOSD. As for symptomatic therapy, so pain or spasticity, bowel bladder symptoms may have to be treated with a symptomatic treatment, but pain and paresthesia associated with NMOSD myelitis are usually very severe, and they're resistant to treatment. So it's not easy to treat the pain and paresthesia in patients with NMOSD myelitis. So that's a therapeutic challenge for us.
And in MOGAD?
Yes, so as for NMOSD, also in MOGAD, we can think about treatment in 3 different steps. So acute treatment, chronic treatment, of course the symptomatic treatment, which is very much relevant for disability, and also for improving quality of life of patients, and of course ongoing clinical trials. So as for the acute treatment, we know that steroids, intravenous steroids, are a very important first step. We can also add plasma exchange or IVIG in the acute stage in cases who are unresponsive. But an important point is to do a good and quite low steroid tapering. So we know that we need to taper steroid over a minimum of 3 months, maybe even more, some says 3 to 6 months. And this is quite important to reduce this residual disability and also to reduce the risk of future relapses. This is very much important to mention. And then the point is which cases should be treated with chronic immunosuppression, because we know that, and this is another important difference in comparison with MS and NMOSD, that only half of MOGAD patients, more or less, will relapse. But we do not know who. So, for example, there are some possible indicators like age at onset, the clinical phenotype, and as I mentioned before, monitoring MOG antibody titer, but not the titer at onset, that are linked somehow with disease course, although we do not clearly predict those cases with relapse. So usually the recommendation is not to treat with chronic immunosuppression those cases who have a monophasic disease with a complete clinical recovery. But if we have an incomplete recovery or a relapsing disease course, then we should think about chronic immunosuppression. The point is which one, because as I said, there are not published results of clinical trials, although there are ongoing clinical trials. So usually what we do give to these patients is like azathioprine, MMF, IVIG. They work very well both in adult and children, and rituximab, although it works less well than in NMOSD, and eventually tocilizumab, which has been also used in some few report acute cases. But as I mentioned, no one of these has been demonstrated to be effective in clinical trials, so although in the clinical practice they work quite well. There are two ongoing clinical trials. One is with satralizumab, so an anti-IL-6. We know that IL-6 is quite increased in both serum and CSF of patients with MOGAD, and this pathway is very much involved in the disease. And the second one is with an anti-FC neonatal, which helps the degradation of the antibodies through the lysosomal pathway, which is with rozanolixizumab. These two ongoing clinical trials will probably give important results to treat patients with chronic immunosuppression.
Well, hopefully, potentially we get some of those trial results later in the year. And as sort of a last point on this, for the first time at the ECTRIMS Congress in Copenhagen later this year, we'll have a pre-day that's going to place a large focus on these rare CNS conditions, including MOGAD and NMOSD. As two people who obviously work closely in these conditions, how important do you think it is that we're having, a really strong focus on those? And if you had to pick one thing, what are you most looking forward to at that meeting?
Well, obviously, these disorders should be differentiated from MS, and the most importantly, the treatment is different. But these disorders are relatively rare. So, as Sara already mentioned, they may be under-recognized or underdiagnosed. And I still vividly remember that about 2 years ago, when the ECTRIMS meeting was held in Amsterdam, Professor Martin Torek clearly announced that from now on, ECTRIMS would deal with NMOSD and MOGAD as well as MS. I think that the first ever pre-ECTRIMS pre-day session of NMOSD and MOGAD is a reflection of what she said in the Amsterdam meeting. And by attending this session, you can study everything of NMOSD and MOGAD, which is clearly important in your clinical practice. So I'm very much excited to join this session, and I would like to encourage other colleagues to participate in the session to study all aspects of these two disorders.
Sara, what are you most looking forward to around pre-day?
Yeah, I think it's very much important because, of course, MS, as we mentioned, is more common, but NMOSD and MOGAD are quite common, although maybe up to a few years ago under-recognized. So I think it's very much important for the differential diagnosis of all these three conditions, and also because treatment, if we give the wrong treatment to patients because we did maybe a not proper diagnosis, then the risk of increasing disability and the risk of relapses is very high. So I think it's very much important to focus also on this rarer disease for helping clinicians to do a proper differential diagnosis, establish a proper treatment, of course, recognize which patients should be tested, because it's also important to have a good pretest probability to improve the performance of the diagnostic assays that we order. And then it's also important to know how this diagnostic assay works, how this patient can be differentiated in treatment, because all these aspects improve patient quality of life. So I think it's very much important and is a great for ECTRIMS to focus also on these conditions.
Well, look, I look forward to seeing you both in Copenhagen on the pre-day later in the year, and thank you, Sara, and you, Kazuo, for your time today to talk through what's been a really fascinating episode.
My pleasure, my great pleasure.
Thank you very much.
And thanks everyone for listening. Once again, I'm Brett Drummond, host of this podcast episode. I'm also co-founder of MSTranslate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community. The ECTRIMS podcast is produced and hosted in collaboration with two key partners, MSTranslate and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The ECTRIMS podcast is supported by an educational grant from Roche, Alexion AstraZeneca Rare Disease, and other grant providers. Educational grant providers have no input on the podcast series content. You can read more about the topic of this latest podcast episode and more on the ECTRIMS website, ectrims.eu. Do subscribe to the ECTRIMS podcast on your favourite podcast channels and follow ECTRIMS on X, formerly Twitter, LinkedIn, Facebook, and YouTube.